We are live to the world. Welcome to Dr. TSPR show. This is Dr. Tangella Shiva Prasad Reddy alias Dr. TSPR. Namaste, Adab. Hello, a grand welcome to all the wonderful guests. As it has been, this channel and the Dr. TSPR show is dotted by wonderful guests who always work in public interest, in larger public interest. They favor public with all evidences as per constitution, rule of law, invoking all sorts of evidential acts. So here we have the eagerly awaited show, as we have a wonderful guest in from South Africa. That is right, we are all hearing, but don't bombard me with calls and messages. That interferes with the transmission. You have to understand, we work very hard to bring you live the quality of whether it is video or audio. So more number of calls and more number of messages will really put us into a piquant situation as it has happened yesterday. Yes, it is Dr. Angelique Coetzee, the discoverer of OMICRON. We said, oh my God, another strain. The queen of the show. She is on the live show now. A hearty welcome to the show, madam.
Thank you so much.
Likewise.
And, welcome to all your listeners and viewers.
Yes. And again, don't send me messages. This show has been being hacked regularly. So don't worry. You will be watching it live throughout. We will not go away. That much I can assure you. I hope you will allow me to introduce my other guest, who has been the main strength and pillar, Dr. Amitav Banerjee. He has risen to the occasion. Believe me, he has made my job very simple and easy. At that age, a leading epidemiologist, and he is an adored, admired professor of community medicine of Dr. M.Y. Medical College, Pune. Welcome to you, sir.
Thank you.
Not lagging behind. He's his own Shishya. Now he's in military attire with high altitude of energies, embodied energies. Dr. Arvind Khushwaha. He is additional professor, community medicine or epidemiology, whatever you call, from All India Institute of Medical Sciences, Nagpur. Welcome to the show. And believe me, the eternal guest of the show and Khushwaha, they keep speaking to each other daily. And we said, why do you do in private only making Dr. Amitav Banerjee the eternal source? We said no. We all three combined so that you can speak in the public. That is why this show has happened. Let me give you a brief introduction of Dr. Angelique Coetzee. She is from South African Medical Association, SAMA we call. That chair, she is the national chair of SAMA from 2000, since 2018 till 2021. I think she still continues on that. And she is the national chairperson of that South African Medical Association, a privileged one. She has worked very hard to come to that stage, 30 years of medical practice. She has obtained her Bachelor of Medical Science in 1982, likewise her PG, I think that should be neurology, from University of Pretoria in 1985. And she has more than 30 years experience in private practice. Her professional experience includes inter alia postgraduate certificate in advanced health management, and this should be a warning to World Health Organization. And again, it is a warning to World Health Organization that she is also a postgraduate certificate in advanced health, postgraduate higher certificate in criminal justice and forensic, which is very crucial for this pandemic. I hope I am sounding a warning bell for WHOs and CDC, FDA and all, including ICMR and everyone. Investigations at the Faculty of Law from the University of Johannesburg, 2018. She is currently completing her fraud examiner certificate with the Association of Certified Fraud Examiners. My goodness. Now I only hope that the said organizations will not veto her voice, because she comes from such distinguished background. She held numerous chair and vice chair positions in the SAMA on national and branch level. Throughout the years, she was a member of the National Ministerial TT on Military Hospitals 2013, Chairperson Ministerial Medical on Internal and External Deployment SAND 2014. She was elected as Vice Chair of FIRST, the Medical Parole Advisory Board 2011. She has extensive knowledge of private practice and is a member of various initiatives driving primary health care. She is currently leading Pillar 5 on health service delivery of the Practitioner health system, and not only that, just in she is into Ministerial Vaccine Advice Committee. Now we are going to grill her on that. Definitely, no, don't keep messages. Yes, madam. The first thing, we heartily invite you with a warm namaste, and we say hello to you also. Same adab also. This is our traditional way of greeting on behalf of Dr. TSPR channels. Dr. Angelique Coetzee,
Thank
do you think, is it a boon or bane being part of OMICRON?
Omicron is it's an interesting virus. Is it a boom? Depends on who you speak to. It will always be a boom to all the pharmaceutical companies as long as we've got a wave going on or a pandemic going on. So the Omicron itself, I think it's always important to understand the clinical picture. I know there's a lot of scientific background. I know that the scientists are warning us to say, please be careful what you say regarding severity of the disease. The problem is, at primary healthcare in South Africa, so it might be different in other countries. In primary healthcare in South Africa, we are seeing mild disease. We know that there's vaccine waning. We know that the efficacy of the vaccines, especially Pfizer, is in all cases is, I'll give you the numbers, is 30%, 33% less effective. First 2 months post second dose, and 3 to 4 months post second dose, 25% effective. So we have seen that in our patients. So we have seen our patients getting breakthrough infections at primary care level, but we've also seen that even though they get the breakthrough infections, they still handle the clinical symptoms much better than the unvaccinated people. It's less. And we have also seen that although the vaccine's efficacy is waning in the community, that our hospital admissions are mostly unvaccinated people. We have also seen in this Omicron wave that our hospitals are still not overrun. Our Minister of Health this morning announced that we will not go into any stricter lockdown because of the fact that our hospitals can, at this stage, handle the cases coming in. We know that our death rate is far less than it was in the 4th week of Delta. And so the bottom line is, it's a fast-spreading viral infection, and it might be more fast-spreading than Delta. The time will tell us, but it's definitely fast-spreading. It might be that because it's fast-spreading, because it's got more than 30 mutations, that it lost some of its efficacy and severity, not efficacy, the severity of the disease. It might be, because that's more or less what we see in the South African context. But we have been told that, because it's so fast spreading, especially in the first world countries, that their hospitals might be overburdened by these patients coming in. And we have been told that South Africa's got a lower a lower aging population, and we have been vaccinated. All of this might be true, but still, if you look at our population and the vaccination rate, we less than or about 40%, 42% of our people has been vaccinated or above the age of 18. We know that above the age of 50, between 50 and 60, we have around about 50, where am I? 65% vaccine or vaccinated people. So we know all of that, and we know that our people also get severe disease, as in any other country. Currently very difficult for me because if you look at certain of the European countries, it is clear that they want to say to us that this is extremely a very, very dangerous virus, and it's a virus with severe clinical picture, apparently. So what I can say is that in South Africa, it's mostly a mild disease. Yes, we do have hospital admissions. Yes, they are sick. Yes, they are mostly unvaccinated that's in the hospital. And for the rest of the European countries, maybe they will have a severe hospitalization, which we don't see in our country. I hope that is not what's going to happen there. And also, I can't really understand why hospitals will be overflow. If we in South Africa, if we look at our yesterday, we had 26,976 positive cases, and still our hospitals are not overflown with severe cases. But it depends. It depends on how you get the message out. It depends on how you listen to your people at the ground. It depends on whether you bring your doctors at coalface in. So what I've noticed is that through all these waves that we have seen, the actual voice of the doctor, the clinician, at coalface or at ICU level, it's not being heard. We hear all the scientists, which is important. We have to have the scientists, don't get me wrong. But we hear the scientists, we hear the politicians, we hear the pharmaceutical companies speaking, but we don't hear the people, and we don't hear the doctors that's working with this disease. And I think we need to change this narrative, because in the end of the day, it's the doctor at coalface that's going to tell your scientists what they are seeing. Scientists need to listen and then to say, okay, this is what is happening at ground level. What can we do? Are the doctors correct? Are they wrong? So it becomes very difficult if the doctors at ground level are telling you we don't see that severe cases, and everyone is saying to you, but it should be severe. If you look at the genomes, if you look at the mutations, and so do we now need to lie out there and say, yes, this is extremely severe, it's an extremely dangerous virus? Remember, all viruses are dangerous. There's not one virus that's not dangerous. Chickenpox is dangerous. If you are not vaccinated and you're 60 years of age and you get chickenpox with comorbidities, with uncontrolled diabetes, for you it will definitely be severe. So how do we get the narrative out there that you should actually just be calm, watch this, look at your clinical space, speak with your doctors, listen to them, empower your patients with the clinical picture, and let's see what is happening. We didn't do this with Delta, and we paid the price of Delta because patients arrived too late at the hospitals, too late at the doctors, when they were already in severe disease. And if we do not empower them and the doctors first line, we're going to make the same mistakes over again, and we're going to say every virus is a severe case instead of saying, let's see how we treat them at coalface level. I hope this makes sense.
I hope this makes sense to the vaccine manufacturers too, and but the other flip side, you really the narrative should be people and doctors. That is what we always want. Let people speak. Let the doctors who are in the front line, not the associations. Associations now, Indian Medical they say they're threatening this wave, that wave. Even I'm a doctor by profession. How can you predict that there will be this wave affecting this age group and this wave going to affect this age group? Your eternal experience, and you have so many law degrees. Do you think you can frame it that way? Oh, this wave will spare youngsters. This wave is going to affect youngsters. What is this happening, madam? Is this science? And the other part, the flip side is, how did you come across Omicron? Now, do you think this already people have come out of Omicron? I mean Delta. Now Omicron, Dr. Angelique Coetzee, he has created or reinvented another strain again, which is going to destroy the peace and health of people by simply creating fear psychosis than real health science.
Now, it is so important to keep the balance, to keep the balance what is happening, and to be open and transparent, and to speak to the community or to the citizens. I'm always saying you have to take them on the journey with you. You cannot expect people to be terrified only knowing they need to get a jab. They don't actually know why. They don't actually know what is going to happen to them if they don't take it. They don't know if they make a choice, whether they're making the right choice of not taking it, and they don't even know what medication. And quite a lot of doctors doesn't even know what to prescribe because no one told them what to prescribe. No one said, listen, I see the same patients than you. This is maybe working in my country. What is working in your country? Let us speak about it. Let us be open about it. So it is like going to a war and everyone is telling us the enemy is coming. The enemy is dangerous. Please go and hide in your home. I will give you some gun. The gun would be a shot, your immune booster or your vaccine, which is correct. You have to have a gun. Please don't get me wrong. You have to have it. But then go and hide. And don't get out of your house. And if I ask, why can't I get out of my house? And they say, no, this is this enemy. But no one, and then if I ask, how does the enemy look like? And you say, don't worry, the enemy is here. Just go and hide. We have to be able to tell the people how the enemy is looking, how the Omicron virus is behaving, how the Delta is behaving. When do you need to go and hide? What can you do to get over this, to make it easier? Because we have to live with this enemy. It's going to be with us for quite some time. It may become endemic. It may dress like us at the end of the day. How do we understand this? And we're not there. We are telling, please, going to have doubling of your numbers every second day. We're going to have no space in the hospitals. People are going to get extremely sick. And then, so everyone thinks that they are now extremely sick. So don't get me wrong. If I say you've got a headache, the symptoms of Omicron is very easy. It is the myalgia, that body aches and pains, the severe headache, and the tiredness. It's very much like flu, that tiredness that's in the body. But the unvaccinated people, I normally say they've got the mother of all headaches. So it's really a very, very severe headache. So if you are experiencing this severe headache, you might easily think it's meningitis or encephalitis. And you might admit this patient, while it's actually Omicron. And if you give them anti-inflammatories and just watch them for 2 days at home, you will see they would improve, as well as cortisone. That is the baseline of the treatment is something like ibuprofen, Panado, or you call it paracetamol, and a very low dosage of cortisone. So the beauty is in Omicron, you can start actually immediately with the cortisone for 5 days, very low dosage. With Delta, you have to wait because you know that patient might crash on you, and you need that cortisone later on to get them out of trouble. So you will not start early with that. So with Omicron, it's totally different. So you don't need a lot of medication. You don't even need oxygen, but you need common sense. You need to tell your patient what to do. You need to tell them when to go and test, and you need to empower your doctor, and you need to get your minister or your health ministers to make sure that there's enough vaccines for those that want to, and it should be accessible. It doesn't help you say, I've got vaccines, but people doesn't have the means of transport to get there. There's no money to get to the vaccines. The vaccines should go to the people. The second thing is we keep on saying that you need to wear your mask, your hand wash, and your social distancing. We call it the non-pharmaceutical interventions. The important thing of that is government must enable you to do that. So if they don't help you with a clean mask every day and you wear your face cloth for 5 days or 6 days, you're going to be in trouble. If you don't have running water to wash your mask, how do you expect that patient to wear a clean mask? If you don't have sanitation, if you don't have enough transport so to make sure that people that in a taxi that can only take, let's say, 20 people. We know in South Africa if they can get 40 in that taxi, they will put 40 into that taxi. So how are you going to do social distancing? So you need to enable your people to get that right. You need to make sure that they get the vaccines. What do you, as a citizen, a responsible citizen, need to do? It's a 50-50% partnership. A responsible citizen need to get your vaccines. You need to make sure that you don't get into a taxi where there's 40 people and it can only take 20 people. You need to make sure that you get a clean mask from government every day. And then the third component is get your healthcare workers, the doctors that works with these patients, empower them and give the symptoms to the patients and tell them when to do A, B, C, D. I think it's so simple, but we tend to make it so complicated, extremely complicated. Then again, with the vaccines, I will stop now. I mustn't get going because then I can't stop, but I must stop. So,
vaccines, I'll
so
come back to you.
Vaccines,
I'll come back to vaccines. But for me,
okay.
Yes, I'm going to grill you on vaccines because many questions have been shot at. But before that, how did you come across this Omicron, a different strain? Is it really a different strain? People have got all worries, or else they say, is it pharmaco-backed again, another threat, psychological threat which is being unleashed on the innocent people of the world?
No, it's definitely a different strain. The clinical picture very clear. Remember, I have treated myself physically, not via any platform or telephonically. I've treated over 600 COVID Delta patients myself, so it's quite easy to spot the Delta by this time. And when I saw the symptoms that didn't fit in with Delta, after we have actually not seeing any Delta patients for at least 8 weeks, 8 to 12 weeks, 8 to 10 weeks. So then that morning to sort of encounter a new clinical picture, and they're definitely positive. And from there on, you saw the numbers rise. So this is the beauty of being a clinician. You actually pick up the problems before the scientists. You should advising them that, look, there's a problem, go and see. We actually also saw the vaccine efficacy waning during the third wave, and we warned and say we need to, our healthcare workers need to get a booster long before the studies came out. But that is clinical. You're on the ground, you are hands-on. That's why you know this, that's why you see it, and that's why you can advise on this. But people always take it as anecdotal, and then again, what does the average general practitioner knows out there, and what does the average specialist? They're not high enough qualified to be all these very important people.
So you mean to say
GPs.
some cases which escaped out of the Delta variant like symptoms, so you became inquisitive, and that is how you landed on Omicron. Oh my God, again. And that too, as you clearly stating, that vaccine efficacy waning in those patients.
Yeah.
So now here.
Yeah.
Right. Now this is what is a big issue. The vaccine efficiency waning. Delta has become Omicron. And that is new set of symptoms as she found out. And she really clearly relates, because we are all old type of practitioners. We believe in listening to the people, those who come to us with dis-ease. Once their ease is disturbed, they come to a clinician. That is what we said. Family practice or clinical practice is more important than all these corporate cultures. Reckless corporatization, wherein you miss out all these symptoms and you treat all one. Am I right, madam? Is it true?
Yeah, you're absolutely right. Yeah, no, you're right. I think doctors are neglected, and why everyone wants to become a doctor, and once we are doctors, we keep quiet. Should not.
Should not. That's it. Then that's why you are here on the show for the first time in the world. I think you are coming out very openly, exclusively on Dr. TSPR channel. That is one aspect. The other aspect is, what are the cardinal symptoms which you feel are much different from the SARS COVID 19 and then the Delta strain to this? Oh my God.
It's got less respiratory tract infections, or a less upper respiratory tract picture. It's very, very mild. If you have, so the patients, the predominantly is really, it's the body ache and pain, the myalgia. They will tell you it's very sore, the headache, and the sort of the fatigue. They will then say to you, I've got a bit of a scratch in my throat, but I think it's a post-nasal drip. Or they will say to you, I've got this cough, but it's a dry cough. I don't know whether you have ever heard an ACE cough. An ACE cough is that dry
Here, that's
type of cough.
Irritating one.
Yes, and they do have that type of cough. That's very interesting. So if you immediately hear the ACE cough when they start to cough, and they don't even notice it that they are coughing. That irritation that's there, and that's the main symptoms. So there's no loss of smell, there's no loss of taste, there's no oxygen needs at primary healthcare level. Very mild tachycardia if it is there, but it also 2 or 3 days later it's gone. Temperature, not really temperature. The children, however, will have a sore throat. They will say to you it's a sore throat, and they might have a slight temperature. Again, they might have tachycardia. So if you start, I've given them what we call Tamiflu. That's what you will normally give for a viral infection. And so whether or that helped or not, most of these children were better within, again, 72 hours.
No, wonderful, because you are trying to be very, very outrightly spoken. 2 questions to you. When you said it is tachycardia and the temperature, the body's first defense mechanism is, once it starts, the temperature increases. As doctors, you feel and I feel, we will not suppress it in the first instance. And tachycardia, because of anxious states, the tachycardia will be there, because once patient becomes anxious, it is bound to rise. Don't you think these two are correlated to the immunity as well as anxiety of the patient? So don't you think clinicians should understand this very much, so that again they should not land into other aspects of the missing the logical sense of the diagnosis?
Yeah, they can. I fully agree with you. What I have also noticed, now if you can go back to Delta, in Delta they will have a real tachycardia, and you can see it when they walk. If they walk about 5 or 6 steps, I normally say from the desk to the bed where I examine them, you can see that tachycardia, but that's a tachycardia. That's 120, 125. And after a while, it comes down when they lie. And then they will have the tiredness. But that's a different clinical picture. So with Omicron, I don't really see that. That's why I say it's a very slight tachycardia. It's about 100 and maybe 110 if it even goes that high. It's normally about 102, 103. And it's not all the patients. And I agree with you. I think there's a bit of an anxiety because they know that we're going to test. So no one, a lot of people are very, it's not a nice test to do the nasal swab. I don't know whether any of you had a nasal swab before. It's not a nice test. So it's waiting for you. Coetzee is going to do that on you. And then that bit of anxiety, do I have this or not? Yes, I fully agree with you. And the temperature, I don't even treat it at that level because in any case going to give you anti-inflammatory for that myalgia, to try to help you to get through the headache so that you don't take a lot of other tablets if you can tolerate it, if you are allowed to take ibuprofen.
Now you can, because by your statement it is very clear this is a very, very milder disease when you compare to Delta. As the symptoms you present, and you have your clinical experience, you have treated also. So when such is the case, why hospitalization, why this care in the entire world? When South Africa, how did you diagnose it? Now let me, how did you separate these mutations? How did you come to that? Did you seek the help of a scientist? How did you? This is more important.
They did genome testing because I was not the only one. The lab also offered another patient on the PCR test. There was a loss of a S gene. and that was you normally have 3 genes, and with the PCR there was an abnormality, and they also, but it all happens at the same time, that we alerted and the laboratorium Lancet also alerted NICD. Then they did the sequencing. Dr. Oliveira and Prof. Slim Karim, they did the sequencing. Took them about 3 or 4 days, and then they came back to us. But when it was announced to the world, we already was 1 week into it. We were still trying to figure out how to treat these patients, and you know, you use your skills and your knowledge that you acquired during Delta, and you don't know what you are working with. So maybe it's worse than Delta. So the first few patients you prescribed a lot of medication, you let them come back, you follow the protocols. But then after a week, actually after 10 days, we realized this is actually very easy. These patients doesn't even want to come back for a follow-up. They tell you, doctor, I'm fine. I'm not going to waste your time. And there's no reason that I don't believe them. So up until today, sitting here, I have now seen 90 plus Omicron patients myself. Up until today, I cannot give you the clinical picture of a patient that needs hospitalization. I cannot give that to you because I haven't seen it. And so my colleagues.
Wonderful. When did you come across the first case of Omicron, when you announced it 1 week into the world?
It was the 18th of November. Today, 4 weeks ago.
4 weeks ago, 18th of November. And believe me, this has started in South Africa itself, the birthplace.
I don't think it's not. Didn't start there. Very interesting. The new data shows it started in Europe.
But how is that now they all come to say this has started in South Africa, and Dr. Angelique Coetzee is another co-inventor with so-and-so doctor from America?
No, they missed it. They missed the PCR tests. They missed this S gene. They missed the clinical symptoms because they were so focused on Delta, and maybe they didn't treat their patients themselves.
So they had sufficient stock of Delta dash, so they could not. So they missed it. But anyhow, the first diagnosis has happened from Africa. You were the first one to announce. Am I right?
Yes.
To the world.
Yeah.
Am I right?
Yeah.
Okay.
Yeah, that's right. Yeah,
This
no, that's right.
Now,
And only after we announced it, people went back to that, because with sequencing, you can go and sequence and see where did it actually originate from, and the latest is actually it started in Europe, which I told them when they slam us with the ban. I said, you slam South Africa with a travel ban. That virus is already in your countries. But what do I know? I'm just a GP.
you are just a GP, great practitioner or general practitioner, whatever it is. God bless you. But let me not miss the count on what we are trying to speak. How do you think that the same RT-PCR, the same rapid antigen tests are the only ones to explore or to diagnose?
Well, that's all we have in South Africa is the rapid test and the PCR. So what you need to do, let me give another example.
Yep.
Because I've been asked, how do I know it's Omicron? Because our rapid test is not telling us it's Omicron. So I said, how do I know a patient's got pneumonia? I listen to the patient, I examine the patient, I pick up the abnormalities in the lung. So then I need to do the X-ray to confirm, or blood test to confirm. So it's the same with Omicron. I look at the clinical picture because the clinical picture stays the same. Doesn't matter how hard I try to get the patient to tell me something else. So the clinical picture stays the same. You examine the patient, and then you confirm it with a rapid test. And if the rapid test or the PCR is positive, with the clinical symptoms in front of you, you know it's not Delta. You know it's not Beta. So it can only be Omicron that has been diagnosed. And so the world wants to do it the other way around. The world wants everyone to test and forget the clinical picture and forget there's a patient that needs to be examined. And that can't work like that. So your PCR and your rapid test is extremely important. It helps you as a tool to say, yes, it is indeed, you're right with what you are saying. or what you are clinically experiencing. But it should not be the first and only tool that you use. That's wrong.
Let me help you in putting it this way. What is the evidence that these clinical features are due to a variant of SARS-CoV-2? Because is there any way of confirming it in clinical practice other than what you are trying to? How can you say that is another variant of SARS-CoV-2, another variant of SARS-CoV-2?
Well, we have to listen there to the scientists who said to us, this is SARS-CoV, this is a new variant, and the variant's got so many spikes, so many mutations and proteins, and this is the name of the virus. So they could have called it anything that they wanted, but that's how we. So it's the same, it can be something else, but we think it's COVID, but it should be COVID because of the fast spreading, still a respiratory tract infection, although very, very mild.
Because
it's not an easy question. I know what you want to say, but clinically, I will still stand. That's Omicron. I know that's Omicron. Because that's what I know that's pneumonia. It could be something else, but it's pneumonia.
May not be SARS-CoV-2. It may be anything else too.
Yeah, it might be. But clinically, that they call it the name SARS-CoV-2.
No,
how do because call it Omicron?
You are my wonderful
that's
guest. Now you are my wonderful guest. I don't want to tax you beyond, because these are the questions which are being shot at me and very other vulnerable. Because see very clearly, what is the evidence that these clinical features are due to a variant of SARS-CoV-2? Which scientist has helped you in identifying these genome sequences and relating it to SARS-CoV-2, naming it as Omicron, oh my god, another strain, when Delta variant, we could clearly explore, it is not this people are dying because of COVID, various other comorbidities, and because of unwanted and under trial vaccines which have destroyed natural immunity. Once your fear psychosis is down, as a doctor, you know what happens with your immune system. The way your exteriors, the interiors are also gone. That is how you land into the cytokine storm when your own body starts destroying you, autolysis. So that's why the people are inquisitive. They're asking you, what is the evidence that these clinical features are due to a variant of SARS-CoV-2? Which scientist you think would have isolated this at your place?
Well, the scientists that isolate this virus or this new variant is our South African scientists.
Okay.
It is very well known, very respected, and I have no reason not to trust him. At least I trust them. I know them. I've worked with them.
We trust him. Through you we trust him. It's not that, because at least you had that commonest of the commonest experiences to tell the world this is very mild, and even your scientist clearly stating that this is nothing but another variant, not something different which can disturb and destroy the world. That is where we say kudos to you. That's why we are asking you is, after the people had doubts regarding Delta variant, because Delta variant happened only because of immunoescape. When you started to hit COVID with unnecessary under trial vaccines, which still today still being used under emergency, name of emergency. I'll come back to you later, that vaccines aspect. But how sure you are that you would relate this to as another variant of SARS-CoV-2 after Delta? Because me and Dr.Amitav, we have done a series with cricket. Yesterday also we played chess, and before we could end, technically they tried to destroy it, but we have won the match. So likewise, we have related before that with cricket, along with Khushwaha ji also was trying to play a milder game, and we said it is from a limited overs game, a virus, it has gone to test match. First new ball, Delta variant. Second new ball, oh my god. So this oh my god, how sure you are with clinical background, with law background, with fraud certificates, investigator, how sure you are that this should be a new strain of SARS-CoV-2?
I'm very confident. After 33 years in private practice, seeing the same pattern over and over again, it's the same. How do I know this is tonsillitis? How sure am I this is tonsillitis? Well, I open the mouth, I look, I see, I diagnose, and I know I'm right. And this is yeah. I stand by what I'm saying. Omicron, mild disease. Don't care what the rest of the world is saying at this stage. I know that maybe their hospitals might be overflow, but I would love to see the severity of those cases. Even the case that was now recently been announced by Great Britain of the one Omicron patient that died. You know, these questions I would love to know: was it Omicron itself? Was it related to a patient who had maybe another type of disease and died and coincidentally got infected? So what was the clinical picture? So I would love to hear that, because I have not seen in South Africa currently the clinical picture of severe Omicron. But there are people that's really, really sick with respiratory tract infections. And unfortunately, our lab in the ICU do not distinguish between Omicron and Delta. They will only tell us this is COVID.
Okay.
And so I still have that question.
For me, having you on this show, because we want to see that clinical practitioners stay alive. My job because we and Dr. Amitav Banerjee or Dr. Khushwaha, we wanted traditional medicine to be practiced all by doctors. Doctors should speak to the world, because doctors are the ones who diagnose and treat, and who also play an important role in prevention of disease. It should be doctors. Don't you think it should be doctors who should speak? And people and doctors, why the hell these politicians, administrators, and they are funded by our taxes, madam. We vote them to come to the power to look after our welfare and our development. But don't you think though they should allow us to work? This pandemic, it's a health crisis. How can you turn this into a law and order issue, threatening people with all these norms? And you are very categorical and clear. I hope the entire world is listening. At this point of time, there is no severe disease of micron, what is the OMICRON variant in South Africa, from where this disease has evolved. Then how is that the entire world is getting scared? That is $1 million question. She is emphatic. She is very categorical. Am I right, madam?
Yes. I'm not saying that some of those patients in ICU doesn't have Omicron, because I don't know.
They have to be proved.
I would love to have that.
They have
data,
to be proved.
But they are COVID patients. Yeah.
They have to be even COVID patients also. We have been requesting, demanding, how did you diagnose that he has died with COVID? Where is the autopsy report? And where are the clinical symptoms? The case sheet should be made public. And what is the treatment line, madam? WHO went on changing from remdesivir to all cocktails, and they went off again. Where is the line of treatment? And don't you think though this fear psychosis and this unwanted treatment, this I call them drug trials, would have caused these type of deaths? In America, every year you see Europe flu deaths. Now where are those flu deaths? Except corona, we don't see anything else. So every other disease is being labeled as COVID. And now you think, because you are the discoverer of Omicron, don't you feel that even this is going to play havoc with public life in a similar way what has happened during this pandemic? What should people do?
People should understand the symptoms. They should, again, if they don't have a problem, and they don't, I'm still for vaccines, because I've seen that it helps with severe disease.
I'll come to you. Next question is regarding vaccines. I'll come to you. First.
So what does people need to know? They need to understand the symptoms.
Yeah.
They need to look at themselves and see, do I have this, or do my brother have this? What do I then need to do? If my brother has this, what is the next step? What is the doctor? What are you going to do? How are you going to help and assist here? So we need to focus it much more on primary health care, because that's where the people first go to. They don't first go to the specialist. They first go to the primary health setup. And we need to teach the people there what to do and how to do it.
Wonderful. That is what we have been trying to tell people of the world, the rulers of the world, that primary health care and public health care and with awareness involving people. That is the only way we could get out of this pandemic. The other aspect, as a clinical physician, don't you think as the virus mutates, it is going to become weaker and it will be very mild as it and it will become endemic. Don't you think we have to live with this forever?
We'll have to start living to understand that we have to live with this. I fully agree. I also think it will start to get endemic. It is not in the virus' best interest to kill people, because once if everyone is killed, you will also be killed. So it's in the virus' best interest to get a warm body that is not too severely ill, so that he can mutate and live very happily with that person's or that host. So my gut feeling is that yes, you might be even seeing variants even more fast spreading than Omicron, but hopefully they lose their severity. So one of the questions would be, why do you need to mutate so much and only cause a fast spreading and lost a bit of your severity if you combine it or compare it with Delta? So Delta is for me. Delta is extremely scary. I have seen what it does to people. I've seen how people die. But again, if we have spoken out during the Delta pandemic and empower the people, I think we would not have seen that death rate and the hospitals that much overloaded. It would still have been a problem, but less.
But during Delta, all those people who stayed at home, they recovered. All those people who went to the hospital, they died. How do you look at this scenario also? Don't you think drug trials, the fear psychosis, unhygienic atmosphere prevailing, and unnecessarily blaming entire doctors fraternity because of some commercial leanings of some people, it has destroyed the faith of this practice? Then I'll come to vaccines. Now, don't you think these people who have been vaccinated, fully vaccinated, are allowed to fly in between the countries? Now, if this Omicron or oh my God has spread, don't you think it is the failure of vaccines and those vaccinated?
Well, you see, in South Africa, right from the beginning, we told the people and we advised and we said, you get vaccinated so that we can keep you out of hospital, that we can see less severe cases, and that death rate is also coming down. That's why we try to vaccinate you. We told them.
Hear me, because you are a clinician. I'm catching you here. Vaccine is a prevention or a drug?
Yeah, it should prevent.
So it should prevent only.
But it can't prevent 100%.
It has to.
There's no vaccine.
No, it has to prevent only transmission.
No. It should prevent transmission. It should prevent also, the severity. So
how can you say severity? When you say severity, it is a drug again. Vaccine should not be a drug. Drug should be given as a treatment for a diagnosed disease.
That's right.
But if you use vaccine for a preventive, like a drug, it will destroy the natural immunity. That is what is happening. We have seen Israel. Israel studies are in front. Europe, US, India, Patanam Titta. 2 vaccines, but after that Delta comes out. Because they named Delta because to overcome this vaccination. Now I ask you straight question. Don't you think, in spite of vaccinated, double dose of vaccination, allowing people to fly, and if they are carrying, what is the efficacy of this vaccine? How safe these vaccines are? Where is the immunogenicity and peer review?
Well, we know that that Pfizer, after 4 weeks, 3 to 4 months post second dosage, is 25% protective in all cases. In hospital, it seems to be that it's 70% effective. So that answers your question. So you cannot expect, or you should never fool yourself to think that the vaccine is going to protect you 100%. And any pharmaceutical company saying that the vaccines is going to protect you 100%, I think you can take them on, especially if you get sick, because there can't be a 100. And you need to be honest with the people. Even your flu vaccines are not 100%. We need to tell them. We also need to make sure that if you get your measles outbreak, was it the cold chain that was not followed, or was it waning off that specific batch that was used? Was there something there, or just simple waning of immunity in a certain population?
Right. The last one before I get epidemiologist to speak. Do you think natural immunity is better, or these forced vaccinations which have under trial, still being used under emergency use authorization, even after Delta and Omicron? How can you say vaccine efficacy has got? If that is the case, why they are not liable and why they should not be compensated if they are so sure?
So the pharmaceutical companies made sure that in their contracts that there's a clause that says you cannot sue them.
Why not? Why not? See, if they are, see, I feel
the governments don't ask me why they have. Me and you can speculate, but
no, we are not speculating with health.
On governmental
No,
level.
I am not speculating here because I am speaking to one of the most adored and admired a clinical physician. I respect you, and you have got law also in your hands. Before I show how WHO, World Health Organization, is being flip-flopping, once they say, oh, stop all this nonsense, allow people to fly. The next day they say, no, it is going to be fast spread, again vaccines. Now I am asking, because of vaccines, these diseases are, as you write, strains happening. New strains, why? Because of vaccinations. You are trying to play with the natural tendency of the virus. It is immuno-escape. And now, again you are scaring people into submission. That's what I'm trying to tell you. Vaccine is a science. There are many good vaccines. But in 5 months, and now you are saying every different variants, 35 mutations, how can you have a vaccine of the earlier SARS-CoV-2 seems to be working when it is mutating and Delta variant is there, oh my God is there? How do you think these vaccines will work? And don't you think they are simply interfering with the natural immunity? Just destroying the public exchequer. The money this should have been utilized in India, we say malaria, dangerous disease, killer disease. WHO itself came out, tuberculosis. Because of concentration on COVID, the diagnosis went awry. 42% could not be diagnosed. And how much danger it is killing? Now that is what I'm asking. Where is the proper certification of COVID deaths? Now don't you think science is taking a back seat and pharmaceutical sense and insurance and politicians and their helpful media is creating this panic? Do you think we should fall into this line, this narrative? Had vaccines worked, why Delta and Omicron? Simple and straight. Now again you say booster. How long it will go on? If first dose doesn't work, you have seen Israel is destroying its population. 2.5 crores, madam. Only those unvaccinated with natural immunity, they have got 17% more robust immunity. Double vaccinated, booster, hospitalized and dying. It is the data is in front of you. I'm not saying it is a government data. And still, how do you watch for such vaccines?
So if you look at the South African data, unfortunately the patients in ICU is the unvaccinated people and not the vaccinated people. So that's a very interesting discussion and debate. But as you said, it would be very nice if we have the concrete evidence about what is happening in ICU. And we know why the patients are dying off. We know the immune system. You actually you actually fight yourself with your immune system in the end of the day. But it would be very helpful if we know, is it Omicron, is it Delta, are the vaccines working? But for now, unfortunately, the unvaccinated people are lying in our hospitals. And
but fortunately,
that's difficult for me to get around that one.
And again, fortunate for the world that vaccinated people are carrying the Omicron. That is how vaccines are exposed.
Hopefully. Well, as long as it stays with Omicron and they don't carry Delta, because that is a serious.
No, see, whether it is Delta also happened in those fully vaccinated in India, Pathanamthitta or Israel. Yes, Dr. Amitav Banerjee ji.
Yeah, I have got some simple questions. Like in India, each country has different context. India, the latest Sero survey in Delhi brought out that 90% of adults are having the antibodies. And that time vaccination was just 5-10%. And 80% people below 18 years were having the antibodies, and we have not started the vaccination for below 18. So that means there has been a natural infection has run through the population. So, and the Omicron is also not catching fire in India, because we all countries 136 crores and we have had just 50-60 cases of Omicron. And definitely, as you said, Omicron might be prevalent all over the world. It was discovered first in South Africa. And there was you must have read about it. An Israeli doctor had gone to UK and came back from UK, and it was found to have Omicron subsequently, before it was discovered in Africa. That means, as you rightly said, it was earlier in Europe, Omicron. And it depends on the number of replications. And India is such a large and congested population. Number of mutants must be already existing, and Omicron happens to be one of them. So once you are exposed to the whole virus, the virus stays in the body for 15 days, 10 days. So we expect that it gives a more robust immunity, which may even perhaps withstand, cope with the new variants. And is there any scientific rationale in vaccinating people who have already recovered from natural infection? That is the question, which is always a debate, that poor country like India is wasting so much resources when 80% of the population already has been having the natural. So is it rational, or we can save the money and focus the vaccination only on the vulnerable people elderly or with comorbidities, rather than going for mass vaccination? This mass vaccination is not preventing the transmission. I mean, we cannot eradicate it. So what is your views on this? Shall we go for
So,
mass vaccination when 80% of the population are already recovered from natural infection?
so there's no studies done which show that naturally, if you had COVID with natural immunity, and you add your booster, that you get or you react your vaccine, then you get actually quite a huge boost of your antibodies. How long that lasts, I'm not sure.
So it is a surrogate measure. This antibody is a surrogate measures. There have been studies that 17 years back, those who have recovered from SARS-1, they have got the T cell and memory cell immunity. The question of public health is the prioritizing the resources. Once you have had a recover from natural infection, booster is good individual level, but for the mass vaccination, isn't it a waste of resources when the mortality is 0.05% in India across the board, and among the below 18 years, the mortality is less than 0.0005? So whether, I mean, at such resources on a vaccine which has not proved itself, every 3 months, every 6 months, it is a matter of health economics also. That one question. Other question is, even everybody is conceding now. The manufacturers are also conceding that the vaccine does not prevent transmission, but it is preventing severe disease and hospitalization and death. Agreed. But
Yeah.
as you have brought out, and as so far we are having Omicron. Omicron is not causing severe disease. Neither Omicron is causing death. One death we don't know in UK just so far. So neither it is causing death, neither it is causing hospitalization. So what would be the end point for finding out the efficacy of a vaccine against Omicron, or even for a booster? I mean, I find this in contradiction in terms ki, and we can just give anything placebo and say that there is no hospitalization and no death from the historical data. So that is my question: ki how can we evaluate a vaccine against a viral strain which is neither causing hospitalization, neither death? That is the end point. So what is your answer to this?
That's a difficult answer. That's a very difficult question. And I think it's going to depend on which scientist you speak
What is
of.
the,
But
it is difficult. So let us watch. Can't we just say, ki, okay, hold on the booster, and then we come back to the general practitioner. Let the treating physician allocate the risk and accordingly have a discussion with the patient. Look, you are 80 years old, you have got chronic obstructive pulmonary disease, you have got CCF, you don't take a chance, you take a booster. You get the point. So as you
No, I
said, we are
fully agree.
losing.
No, I agree
So
with you.
therefore,
You need to, you need, before you start with boosters,
but
you
that is not
first like
happening now. In Israel, they are saying if you don't have the third dose, you are not vaccinated. You are incomplete vaccination. So it is just, isn't it waste of resources and amount of adverse events? We don't know. They are myocarditis, young people. I mean, we don't know. I mean, and particularly forget about the side effects, but the cost. In India, we have got, as Dr. Reddy brought out, 2,000 children die every day in India from preventable diseases, from typhoid, from diarrhea, from dengue, from Japanese encephalitis. Lot of children are dying. 1,400 people are dying of tuberculosis. Young people are dying daily. So this money on a disease which has got, now Omicron has come, it spreads very fast. So won't it increase the herd immunity faster? I mean, so each country should decide, because European countries are not so population density and they are very elderly people and they have got obesity. In fact, if you see the South Africa population also, their obesity rates are almost on par with the European countries, South Africa and Egypt. And they are having the higher mortality. Japan has got a very old age, but it has got a very lean population. Their obesity is on, and they are having a very low mortality. So these features are also there. So accordingly, I mean, you can save on the vaccines and the resources if you can identify the risk group. So that is, as an epidemiologist, these are my inputs. And I would say that one has to leave it to the general practitioner, the family physician, which is, I think South Africa is having more physicians now. India also, we are going to the specialization and corporate hospital. The private practitioner is a very, very endangered species, and the personal care is not there. We are having the guidelines from the pharma companies, from the government, and from the, in fact, from the police also, that if you are not vaccinated 3 doses, so we are wasting resources. This is my concern.
I fully agree with you. You need to prioritize. I'm in agreement with you with prioritizing. In South Africa, as I said, we have not yet begun with booster shots, except for the healthcare workers, but they only had one Johnson & Johnson. And Johnson & Johnson should actually be a 2-dose if you look at the data. So going forward, we will see what's happened. But it is going to be extremely difficult if there's a new variant on the block in 6 months from now on, and again there's immune escape, and you want to tell people again you need now another booster to make sure that you're okay. At some stage, the people are not going to believe you anymore.
I forget about people.
So it's difficult.
We can resolve this question in a rational way. You roll it out on a select population, see the efficacy, then go for mass vaccination. You are start putting the cart before the horse. You are giving everyone across the board, you have wasted exorbitant cost which people cannot afford, the country cannot afford. After that, you found, no, it doesn't work, you try another booster. So isn't it better to for a high risk group and then evaluate the efficacy in that? Once it is efficacy, then scale it up. I mean, never in history we have gone for eradication before the disease has been identified properly. Eradication is the major epidemiological battle.
Yeah.
It took 100 to 100 years to eradicate smallpox. So we are going for one day or limited overs cricket, which I mean, South Africa also, I think cricket is a very popular game.
So what we did in South Africa, what we did when we started to roll out, we also only identified certain age groups. The others were very cross with us because everyone, wants the booster or the vaccine until they can get it, and then they don't want it. But we started as well with first the people who would be the most vulnerable and who might place a strain on the hospital care system. That's how you start. I fully agree with you. And then again, you can booster as much as you want, but if you haven't made sure that everyone is at least have one shot, so what is the use of boosting the whole time? I know I agree with you on that. You need to be wise, much more wiser in who you choose. And if you boost, and South Africa, what we have said, if they're going to boost, from the beginning of January. Again, it's high-risk groups. We don't boost each and every one coming in. And we also need to look at our HIV patients and the immune-compromised patients, whether you have kidney disease or, those type of diseases. All immune-compromised is not only TB and HIV. But you need to look at those people because they're the vulnerable people. But that's what South Africa is doing. At least we get it right there.
Dr. Khushwaha,
Yes, sir, Dr. Khushwaha ji, please. High altitude military man is on the rise now. Sir, please go ahead. Yes, sir.
Okay. Good evening, Dr. Angelique. I have a few questions for you.
I'm not a scientist. Remember, I'm just a GP.
No. Dr. Angelique Coetzee, you are the chairperson. You are the chairperson of SAMA, South Africa Medical Association, and discoverer of OMICRON. Because now entire world is saying, oh my God. Now you have to answer.
you are in the witness box.
God bless you. Yeah.
Now, regarding this question, both of you have been mentioning this Omicron as Omicron, and possibly, it is present everywhere in the world, so possibly you're right. But otherwise, it's Omicron only. All right. So, beginning with that, why should we term this rise in South Africa, currently there is being faced, as Omicron wave? And why also similar rises in UK or any other places should be called as Omicron waves without having the data as to what proportion of cases are being attributed to Omicron. Just because you've discovered a new variant doesn't mean that it's causing a spike in the cases. Unless we see that majority of these cases are Omicron. That is one. Maybe you never know. The Delta may still be fueling the rise in most countries. And as the data stands, as I know, 99.2% of the genomic sequencing that has been done across the world still has Delta and not the other variants. Other variants are also there. Beta is there, Delta is there. Omicron contributes obviously the least so far. Anyway, that is one question. Without verifying the proportion of cases, we should not call it as the Omicron wave. We should call it a rise in cases in South Africa, which may be actually normal for this season. I do not know what is the season in South Africa now, but we have a flu season going on here, and that's quite natural to expect a rise during the season. And it may be due to any other virus as well. I do not know what proportion of cases are being subjected to other tests. Other viruses, are they being tested or not? Are they being ruled out or not before turning everything onto the SARS-CoV? That is another question.
Thank you. Can I answer? Because I'm going to forget.
South Africa will be given. Yeah, please.
So let me quickly come in here and say what we are. So first of all, it's not our flu season. This is our summer, and we see very little flu. We actually did see flu around about end of October, beginning of November, but it's gone. It was just a very brief flare-up that we had, and we had also our labs is sending us on a monthly basis what is the most commonest diseases, respiratory tract diseases, and whether it's caused by flu or respiratory tract or RSV viruses. That's actually quite dominant in South Africa. But so it's not flu season. That's the thing. That's the important thing. It is not allergic season either. So how do you? So we ask our people out there. We say to them, if you have these symptoms, please go and get tested. So people go and get tested, and then it's a positive. So if we have 26,000 people that went to test yesterday, out of 83,000 people, 83,864 people went to test yesterday, and 26,976 were positive. So if it was Delta, we would really have seen severe cases. We should have seen with that amount of people, you should have seen at least 500 people in ICU. Even though, you should have seen it. But you should first see them at primary healthcare level. That's your first point of entry. You should have been able to see them there. So we don't see them. So we know, again, the clinical picture, because nothing is going to take the clinical picture away. I stand there with the clinical examination of any patient, regardless whether it's Omicron, tonsillitis, pneumonia. I stand with the clinical picture. I'm an old GP, so that one is a difficult one. I will not go out of that one. So if we have seen, if it was not Omicron, we would have seen them at the primary healthcare level. They would have come in. So you can safely say, maybe there's contamination. Maybe there's another type of virus also that tests positive on a PCR or on a rapid test. It's highly unlikely, but maybe let's say there is. So what is South Africa doing? Every 1 out of every 200 PCR tests are sent for genome testing. So they sequence them. So they would have said to us now, look, there's something else also going. There's no, again, Siva asked me regarding our scientists. I really think we've got good scientists. They're very solid. They're not interested in the politics. I think that's why one of the reasons why Prof. Slim Karim, left the advisory committee, because he's a scientist. And he wants to own his work. So I'm fine with that. We need to have an increase in our cases, because, again, we ask them to go and test. So we should not be worried if there's an increase. What we should worry, even if there's 10,000 people tested positive, but 500 are in your ICUs, that is scary. So if you have 26,000 people, and less than 500 there is not so many people in ICU at this stage, but there's not really any high intake in your ICU, then it should be a mild disease. I'm not saying there will not be people that getting severe disease. There will always be people that get severe disease, because that's the nature of the virus, any virus. But the majority are not in the hospitals, and they're definitely not running to all the surgeries. So people also are not stupid. People work this out for themselves. By now it's the 4th week. They worked out. They want to know they're positive. If they're positive, they know what the doctor is going to say to them. It's going to say stay at home. So if they're not really feeling sick, they will not come into the surgery. But at least they know that they are positive. And hopefully they will isolate. I've got my doubts about this, especially on Omicron, around Omicron. I think because they feel better, the recovery rate is quite good. So I don't think they really do it. But what is worrying to me is, let's say there's 26,000 people, what we have seen, not say that's a fact. I've been trained that, and maybe you can all help me out here. I've been trained that if you get a viral infection, at least 2 to 3 days before you start with symptoms, you are actually highly contagious. And up until 2 days or 3 days after you start with symptoms. So for me, that is quite, I think we are quarantining and we are isolating, but we actually already missed the window period of highly infectious patients. So I might be wrong, but that's how I've been trained. So maybe 33 years later, the virus has given us another story, and I had not been able to get that in any continuous education program that I attended. But that's how I've been trained. I hope this answers your question, Arvind.
Yeah, Dr. Khushwaha, please go ahead.
Secondly, madam. See, South Africa, as I know, has before the Omicron hit the country, the vaccination percentage was quite low. if I remember correctly, it was around 25-30% or even less in most of the provinces. And I do not know of any sero study that may have been carried out in your country. If you can just give me some inputs on any sero prevalence done before the Omicron hit South Africa, if there are any data on that.
No, there's no test being done. The data that we do have comes from our blood donation centers where they do a test. And according to them, a lot of the patients that they tested are positive have got antibodies. So that's data that we do have. But now, not everyone in South Africa is a blood donor. There's always, but that's this data that we have. And how many people are vaccinated in South Africa? About 43% of the adult population are being vaccinated. Remember, we don't vaccinate children under 12, and our 12 to 17 years is not really that large a number of people being vaccinated. And we have vaccinated the children between 12 and 17 only with one dosage. They will now get their second dose one of these days. So for all practical purposes, by definition, they will be seen as unvaccinated, because the definition says fully vaccinated, 2 dosages of Pfizer. Remember, they get Pfizer. And 2 weeks after your last dosage, you will be seen as fully vaccinated.
Thanks a lot. I think you answered the questions very rightly. Another few things that I just wanted to discuss was this the origin of Omicron, as was first pointed out in South Africa, but I think it was simultaneously present in many other countries. And possibly it may have originated somewhere else. And you never know, it may have originated simultaneously in many countries. You never know. So that is something which we will never know in future as well, because we have not been able to even know where the virus originated in Wuhan or somewhere else as well. That those things will never be discovered or they will be uncovered. So that's of no consequence as well. What is important is the current understanding of Omicron. Omicron, as has been established in the last more than a month, clearly is it's a very mild disease that it's causing. Secondly, it's spreading very fast, as is being claimed and as is being documented also. So now we have a virus which is fast spreading and causing literally no disease or very mild disease. So in the long run, you never know, it might be the best friend that we have encountered in this pandemic. You never know. And possibly, with given these characteristics, it is likely to outstrip all other variants in due time. And possibly it is the most suited variant to become endemic in the world. Unless we try to control it and try to stampede it out, this will lead to another variant developing, which will further possibly fuel the next phase. And that's where we might go wrong. So you never know what we are trying to contain this virus may be the biggest mistake that we may be doing, knowing the virus characteristic as of now. And this is the best candidate to really become the endemic virus in future. And that's what I think. Possibly even in case of Omicron, possibly I think the WHO really jumped the gun. Before even adequate data was available on the transmissibility, on the severity of the disease, on immune escape, they just shot at this thing. Omicron, everybody went into a disease. South Africa, every other country closed their doors on that. Now, if this is the kind of medicine we are going to practice, this is the kind of science we are going to practice, no country is going to declare another variant from now on. Isn't that true? So, I think
I fully agree with, sorry you're breaking up, but I think you've got very good arguments. And, that's why I'm saying in South Africa, we do have severe cases in hospital, predominantly mild. And the rest of Europe, we see severe cases because, I've been told that I should be careful what I'm saying regarding severe. I should not say that it's mild cases. So I can say that it's mild in South Africa because that's my experience, and because it seems to me that Europe wants to hear it's severe, severe, severe. So now I'm saying it's very severe in Europe, because I don't know what else to say, because and maybe they are going to get severe cases. I really don't know. But I can't change the clinical picture in South Africa. I cannot change that. It's not me. I've even been asked whether I'm not biased because I was I first diagnosed it, and I would tell you if I think I'm biased, but I'm not biased. It's what I'm seeing and my colleagues are seeing. So again, in South Africa, maybe in India, we will all see mild cases. We will see, however, a few severe cases. It will always be there. And maybe in the rest of the world, we will see severe Omicron. I don't know.
One last question. I have got one question. I'll ask the question because as a family practitioner, as a general practitioner, you are treating children, you are treating young people. So you have been treating respiratory infections all your life. That is the most common OPD attendance.
Yeah.
So whether the H1N1 influenza or other influenzas, whether these influenzas are more serious in children or COVID is more serious in children?
Not Omicron. Not Omicron.
What about the earlier COVID? Was the original COVID also more serious in children compared to influenza?
Not really. We didn't. I can't remember that there was data going out and telling us it's very, very severe under children. Maybe other countries got, but we don't.
Have you come across complications in children due to influenza more often in your career, in your practice? In your practice, you see children more sick with H1N1 in your practice?
No, not with the. We haven't really seen very sick children with COVID. Yes, you will get. If they are sick, they're very sick. Let me just make.
Compared to influenza and COVID, which is more serious in children? Compared to
influenza and respiratory syncytial virus. Yes.
Why we never thought of? Now we are thinking of rolling out vaccine for COVID against children. Why we never thought of rolling out vaccines of influenza on children? Because that has been with us for a longer time. We have got vaccines which are more safer. Why we have not closed schools for influenza? Influenza spreads through schools. Why we are doing this extraordinary measures for COVID, which influenza, which is more lethal, more serious in children? That's my question. What are your impressions as a general practitioner, as a family physician?
No, I agree with you. Influenza is and your normal respiratory tract viruses, you will see a bigger influx of those patients, and they can be quite sick, especially if they are in the nursery schools and creches. So those are the children that will be the most effective. Unfortunately, I haven't seen very severe ill COVID, and I have seen children with COVID.
So actually, therefore, that's what I am saying. When you are thinking of public health priorities, suppose you are thinking of welfare of children, shouldn't you think of those things which are killing more? Every day, 500 to 2,000 children die in India. From this respiratory infection is number one cause, followed by diarrhea. So this is what I wanted to emphasize, that we are chasing only one virus, but more serious other diseases, like as I said yesterday, game of chess. We are only going for one thing, but we are losing major pieces. We are going for a pawn when we are losing the bigger pieces. So that is what I wanted to emphasize, that public health looks at all the diseases, and each country context. European country may not be having those other diseases, other tropical diseases as we are having. So that was the message I wanted to convey.
I think that's a good message.
Yeah, madam.
Your insight as a physician, we are going away from family practice. So your insight is a moderating, and I think we require, my personal age, we require to go back to family practice more and more. We should encourage our
That's
young.
what.
I am a teacher. I find young doctors are not thinking of general practice, which is so fulfilling, which gives you a more balanced and that's why we have landed in this chaos, because virologist is finding something and tunnel vision, clinician tunnel vision, but a general practitioner has got a very, very balanced view, and we should encourage people,
Yes.
make it more glamorous, and we have lost, because of loss of this family practice, we are in this chaos. Thank you, Dr. Coetzee. It was very, very
Yep.
Thank you.
One more
Thank
question.
you.
pleasure.
One more question to you, Dr. Anjali. Most of the Omicron infected cases are mild. Then what is correlation
In
between
South Africa,
Yeah, yeah.
just always in South
Yeah,
Africa.
you are speaking on speaking on behalf of Sama and South Africa
Maybe
only.
you're in Europe.
Yeah. Most of the Omicron infected cases are mild. Then what is the correlation between unvaccinated cases and high number of ICU cases now?
So there's more in the ICU with people tested positive for COVID or people admitted for COVID in ICU. It's 9 out of 10 is unvaccinated people. How many comorbidities they have, what age group they have, I don't know. Discovery will release those data. They normally release it every 2 weeks. So if I get it, I will send it to you. But they will tell us how many are actually because the majority of people belongs to Discovery Medical Scheme, and they will tell us how many is ventilated in the ICU. But unfortunately, again, once if the diagnosis is made of COVID, now you have to also understand the South African claiming process. So if you make a diagnosis, let's say you are in ICU because you've got COVID, but you actually got the COVID after you have been admitted for your heart attack or your whatever other reason. So you will use the codes because we get paid on coding. So you will use the code COVID as the first code. So because then it means the medical scheme must pay in full, so that it doesn't get a lot of monies from the patient afterwards. So in a way, that is just how the system works. So we have spoken about that before. But so in a way that it will be COVID, but you must always ask, what was the other comorbidities? I think that's the question, and not only in South Africa, but in all the other countries.
Yes.
The question is, who is lying in ICU with what comorbidities, what age, and is it a confirmed COVID primary patient,
Wonderful.
or was it secondary?
Wonderful. Ma'am, are these variants by any chance resourced from Wuhan and man-made variants?
You will never know that answer. You will never get that answer. Never.
Mr. Anurag, I hope you got it right. Now, before we say bye, now simple and straight question: how fatal is this COVID?
Yeah, that's a good question. If you look again at our numbers currently, in Delta time we had a lot of deaths. Currently, we saw 54 yesterday. From the 9th of December, 9th, we saw 22 deaths. 10th of December, 49. 11th, 36. And the 13th, the 12th, I didn't put down. And the 13th, 11 deaths. That's what we are sitting.
But how many are there?
But
How many of these are really because of primary COVID?
we don't know.
We don't know. That's a fair
We
thing.
don't know.
The world is listening.
Yeah.
We don't know how many are really
we
because
don't
of. I'm really very thankful to her.
Yeah.
She is very categorical and clear. How many deaths because of primary COVID? No one knows. World Health Organization, CDC, FDA, Indian Council of Medical Research, Union to state governments, all provincial governments and federal governments across the world, hope you are listening. We want data from you. If they are COVID,
There is one paper which is in peer reviewed, and CDC had given that data long back. It was that of all the total deaths, 6% of all were due to the primary due to COVID. Other 94% were due to comorbidities. I mean, with COVID, dying with COVID were 94%. Dying only of COVID was 6% out of all the total deaths. That is in a peer-reviewed paper.
now at least
So
they.
a lot of data is required, and because it's a pandemic of the comorbid and pandemic of the elderly. So they have got a number of comorbidities. So one cause of death is very difficult to establish. And since if you are having this Omicron is spreading so fast, so many people, it may become a commensal in the throat. So you may find Streptococcus pneumococcus, it may find Omicron also, and I can culture Streptococcus and say it is a streptococcal death. So that thing becomes borderless. I mean, this is somehow anybody can start one narrative, because we have investigated outbreaks. Dr. Khushwaha also among military recruits. Normal times we find 10%, 5% carriers. We never labeled them as cases. First time we are labeling even an RT-PCR, a particle, we are labeling them as cases. Asymptomatic people, we are labeling them as cases. Person dies of some other cause and just a RT-PCR positive. It may not have contributed there. It has been attributed as a COVID death. So this type of thing is a lot of it is muddy. That picture is very hazy.
Yeah, Dr.
No,
Khushwaha.
I agree. We need the data. We need the data. We don't have the data.
We don't have the data. Still, World Health Organization, CDC, FDA, Indian Council of Medical Research, all governments across the world claim COVID, Delta, now new Omicron has to be very dangerous. So I hope people understand. This is a science discussion based on science logic. Where is the data? Where is the data?
We may never know. We may never know the origin of the virus. We may never know the end of the virus. Both ends will be.
Yeah, Dr. Khushwaha, you wanted to say something, please.
There is a paper today on the editorial in BMJ that when the pandemic end, it will not come on the channel. It will go on and on if we keep on counting. We are not going to get, as Dr. Coetzee also said, we are not going to get zero COVID level, and it will go on and on. वो हिंदी में भी है, गाना है, कहाँ शुरू कहाँ खत्म. That time we will never know where it started and we will never know where it ends.
Yeah, Dr. Khushwaha. Dr. Khushwaha.
I think we can end this at least this way. We can't continue.
No. Last 2 minutes only. Yes, Dr. Khushwaha. After that, we will.
Just few things that I wanted to actually adding to Dr. Banerjee's this thing only. We are not yet sure when do we label a disease as endemic. In India, 6,000 cases of URI, which is this particular infection is leading to with URI or ARI, acute respiratory infection. We are carrying on testing in lakhs and actually thousands and thousands of people. How long can we continue to test despite knowing that it has already hit the possibly the lowest endemicity levels? What's the point? Once the community transmission establishes itself, isolation, quarantine, contact tracing doesn't work. Simple. That we must understand. So, anywhere where there is a community transmission which is established, even WHO doesn't define when do we say that the community transmission is established. We don't have clear definitions of that. So, similarly, we won't have definitions of when the pandemic will end. Though the pandemic started, but when it ends, we don't know. As Banerjee sir has already rightly pointed out, I read the paper today, it's BNJ wala. And actually, so they can carry on till the point they want. So I do not know, but let's hope it ends soon, and possibly Omicron may be our savior. Yeah, that's what I can.
Yeah, before I take your comment. Pfizer trials have been exposed by British Medical Journal. Now, in spite of that, you are claiming Pfizer is the best one. If such is the case, why still under emergency use authorization? Why there is no liability and compensation? And for a disease which has got 99.99% claimed by WHO only, recovery without any treatment. And when such is the case, now when the worldwide, the herd immunity is setting in, and the suffering countries are those who have been fully vaccinated or gone for 2 doses and now they are going for booster. In such a scenario, do you think that these unwanted intrusions in the name of vaccines, destroying the confidence in vaccines, should be employed for mass vaccination when it doesn't even have the proper definition of stopping transmission? That is one point. The second point I would like to show you, in your own South Africa, the hospitals, children, they are very clearly being shown that there is no hospitalization, but still you recommend vaccination amongst children. just showing this.
Yeah.
Even now, in our this hospital
Yeah.
now, we haven't had,
We don't have. No. Not one single case.
not children, not under 5.
In Europe, everybody gets scared because they said all hospitals are full. Not.
No,
That's not true.
not at all. I'm in charge of the hospital today, and I can guarantee you,
Okay.
we've got 2 cases, and that's adults. And that's it. And we have a 238-bed hospital.
Yeah.
But emptiness. This is how quiet we are. This
Yeah.
is our checklist. Like, quietness.
South African hospitals, children hospitals, still South Africa is going for vaccination amongst children. Without understanding, children have got thymus glands, rich source of T immune cells, and they don't have ACE receptors. COVID-19 cannot bind to their lung tissue.
Absolutely.
Let them prove me wrong. And why the hell they are going for vaccinating children?
Yes. But we've got.
Many such videos. I only hope because of short of paucity of time, I am playing only one video. I will definitely play. We will invite her again, and she's a wonderful woman. We want her to practitioners like her.
That's fine, Mr. Doctor. It's okay.
Okay.
But these are quietness.
Yeah.
I mean, these are done now.
Yeah. I think it's quite enough, but that's.
This is not.
South African hospital, which they claim to be full of patients. Now here is a video shared by the enthusiasts. They're going around all the hospitals showing empty beds everywhere.
8 patients in the whole area.
Still children in South Africa being scared into getting vaccinated. The same fear psychosis
Stuff because
across the globe. Should be an eye opener for all the parents. Don't panic.
yeah. So that nobody is coming now to South Africa because everybody is scared. But it makes no sense for South Africa.
No, we're busy. Our passages are full.
Yeah, of course.
Our visitors always.
It's like a hotel here.
But now it's so quiet.
Yeah, it's quiet.
Right, I think I need to end. Dear, thanks for your video.
It's so clean. It's cool.
Yes, video is a big one. I'll try to.
Ja, cool. Ich brauche nichts dazu sagen. Ich glaube, das spricht für sich selbst.
They've been going to different hospitals because our show runs purely on evidences.
Hier ist auch die Hülle los.
Yeah, go ahead. Finish it fast.
All the hospitals are so full of children dying of the new variant. Can you confirm this?
No, unfortunately, I can't confirm that.
So, jetzt habe ich hier mit der Dame gesprochen von der Security. Die konnte das schon mal nicht bestätigen und jetzt probieren die nochmal jemanden zu holen, der ähnlich wie in einem anderen Krankenhaus die Leitung hat am heutigen Tag. Can you confirm it is true that so many children die here in this hospital because of the variant? No.
You are watching children's hospitals in Africa. How this fear psychosis is being created across the globe.
That the hospital is not overloaded with children who die under 5 years. It's not possible. It's not true. All right. Okay. Ich denke, die Aussagen jetzt auch von dem Personal hier und auch die Bilder vom anderen Krankenhaus haben ja genug ausgesagt.
So, interesting videos from people who send these things, madam. I hope you appreciate. South African hospitals. Coercive job drive breach
South
of
Africa
constitution.
is not
Go ahead, madam. You
We're
speak.
not vaccinating children under 12. So
No, 18 also, madam, up till 18. And why should you? See, coercive job drive, breach of constitution expert. It amounts to breach of Article 21 and 14 of constitution, which says nobody can be forced to give any medication against one's consent. And that too for a disease which is 99.99% recovery without any treatment. And why you should impose these under trial vaccines? That is the $1 billion question. And that is the reason why we are just trying to show all these models which people have been sharing, and how WHO is trying to manipulate the world, CDC or FDA for that matter, or our own ICMR. Where is the data to prove that all these deaths are primarily because of COVID? Am I right, madam? Before we end on a high note, that this show speaks only on science and evidences. Where is the primary data that people are getting killed because of COVID? And when now I ask you, is tuberculosis not dangerous, madam? Don't you think malaria, you don't have vectors there, mosquitoes and flies, typhoid and all? We find Johannesburg or South Africa going without water, and there are many sanitation problems. Yes, madam?
yes, I fully agree with there are lots of sanitation problems, water problems. Yes, malaria is very dangerous, and we know that there is, the medication are not working very well as well. There's resistance. We know all of that, and yes, we have said right from the beginning when the data came out and said that there's lots of children in the hospitals, we went out from Salma side and we said, please, that is coincidental. They're not there primarily for their Omicron or whatever COVID. I think it's better to call it COVID because we don't know which variant it is. So yeah, we need the data. We need the hospital data. At primary healthcare, I'm quite confident because we know what we see, the clinical picture. But at hospital level, we need more data. We need the real data.
At the primary level, and you are also SAMA chair now, and you are also into the committee of vaccine committee. Which disease is more dangerous than corona? Is it tuberculosis, malaria, typhoid? And believe me, tuberculosis from 0 day we start with BCG vaccine of 100 years old. Still, boosters are there. Still, youngsters and old alike suffer, and out of 100, after 6 months treatment, 20 are dying. So, which is more fatal? Is it corona, tuberculosis, malaria, or anything else? As a clinical physician.
That's a difficult one because Delta was very severe. But all of the others are dangerous. There's no, I can't say malaria is less dangerous than TB, especially if you get a resistance TB, a drug-resistant TB. We do see all of them. They're all important. They all will, if you not treat them, you will die from them, or your chances of dying from them are quite high. If I look at Omicron versus Delta, and I put Delta in this category, I must say the problem with Delta is all the in a short period, the high amount of patients, and then the lack of facilities or the lack of infrastructure to treat all these patients. So if while you won't have TB coming in 1 day or 2 weeks, and the whole country's TB are being treated in 2 weeks, and that would also put a huge strain on our system.
No, but when you are not
TB
testing
dangerous, all of them are dangerous.
let me
not
correct.
Omicron.
When you are not testing for other diseases, how can you rule out that people are dying only with COVID? When you are not testing for tuberculosis, malaria, and big sanitation problem in your own capital city, South Africa, Johannesburg, no sanitation, no water. Don't you think those are the diseases which should be afflicting your South Africans more than this COVID? Then why not focus on that? Why you are moving away from that?
We are trying to focus.
Then why?
Listen, South Africa is not taking Omicron. We've made our peace with Omicron. We understand the Omicron. We are not running away with Omicron. South Africa understands Omicron. as I've said, our minister today also said no more stricter restrictions. We're not even going to, whatever is in place is going to stay in place. So it's not South Africa that's running away with it. It's other
Now,
countries.
I hope from the discoverer, the world should be clear. South Africa is comfortable with Omicron. Why the hell you are getting into fear psychosis? Other diseases are there which are killing diseases, and we have challenged in India 27,000 people die every day. In that, how many are from primary COVID? Come on, where is the data? And how many of those vaccinated? Now the world should be very clear. WHO should be ashamed in castigating those unvaccinated. And see, we are there. We have been close to families who got affected, and those vaccinated families. And we are hale and healthy. Twice, thrice we have been tested with RT-PCR. And how sure you are that RT-PCR definitely corresponds to only COVID-19? The second question, these vaccines are made out of first generation COVID-19. Now, variant different symptoms, Delta and Omicron. Then how is that these are going to work? When the first stage itself, when they were not working on the basic COVID, SARS-CoV, how do you think they will work on this Delta and Omicron? Is it not a resourceful waste and trying to threaten people out of their natural immunity? That is the reason why Israel and all, don't you think they are suffering? And why should a learned society like South Africa should also, and India also should get into that? Third, nostrils are meant for breathing, inhalation and exhalation. How long you are going to stuff up with this, all these nonsensical masks and all? And how safe do you think these masks are? And how safe you think by masking people across, you will not allow this to be spread? If that is the case, masking, everything was there, vaccinated people who are carrying this Omicron, is it not ambiguous with our own science, logic and evidences? You finish it, madam.
So again, I think we need to get balance, and we need to get a balanced picture. We need to empower the people. We need to empower the doctors. We need to get the people and the government to be 50-50 in partnership. And we should not, before we start to panic, just first look at the clinical pictures, get basics right, and then you start and spread a lot of fear out there, but not before that. You cannot fight the enemy if you don't even know who the enemy is, but everyone tell you it's the enemy. You need to understand what you are fighting and how.
That's what our military Dr.Arvind Khushwaha last time was stating the same. First to know your enemy. Understand enemy. Understand your own inherent strength. That is your own natural immunity. Hot sun, natural source of energy. You say you want to judiciously utilize solar energy. But how is that you are not using the same for your own natural immunity? Hot water, lemon, natural honey and our natural sun. Don't you think this is more than enough to bring out people out of this disease? And if vaccines are working, why still emergency in entire world? Why still masking in entire world? Why there is no liability and compensation angle if the vaccines were working? Why there is second dose and booster dose if the vaccines were working? How do you look at this scenario, madam? What is the message you want to convey as a clinical physician? Because we want clinical physicians, family physicians to stay alive, so that this corporate culture controlled by pharmacy, insurance, mafia goes for all. They are funding politicians, political parties. I don't have anything to say. But don't you think the public health should be with people and those physicians who are treating them? Not even the others who have got vested interests.
I think so. I think it is extremely important again that you need to look at your foot soldiers, that's your doctors, and if you don't have family practitioners, you need to get them back, because people are not an iPad, people are not a phone call. You need to examine a patient. You need to bring the picture together. You need to advise. You need to be able to say, this is what we are picking up. This is what is of concern. This is who needs to get vaccinated. You have to get vaccinated. If you're not vaccinated, I'm not going to see you next time. And you actually do that because you know that patient is really in need of a vaccine. And you need to prioritize. But that comes back to the prioritizing. And
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 those
again,
vaccines
we
also,
should-
those vaccines also should be time tested, which should have liability and compensation angle going. Like BCG, 100 years vaccine, even after this, people are still suffering. It is not helping.
Yeah.
But how can a 5 months or 6 months old vaccine should be imposed on people unnecessarily for a disease which has got 99.9%? Even elderly, we have proved with statistics, 96-97% elderly also they are recovering.
Well, all I can say is if you're really, again, with Omicron, it's different picture with Delta. Delta, very, very scary. If there's a vaccine that can help you, if you get Delta, not to get severe disease, and you know that you actually don't really need a lot of medication if you get mild disease, that vaccine should be out there. But I don't think there is currently such a vaccine that would give you that hope that if you get mild disease, you will actually not need medication. And we know, again, that for now, there is not enough medication, even in ICU. The oxygen is the most important thing, and then whatever your organs are doing, wherever you are going into organ failure, to try to assist. But the hospitals are not geared for pandemic. Doctors are not trained for pandemics, and I think that's one of the problems. And then the primary healthcare has been neglected for many years, and we are paying the price for that, because if primary healthcare has been working, water would have been available, clean water, sanitation would have been available. There would have been better outcomes. We forget to focus on the people. We forget to focus on outcomes-based medicine, where you treat the patient and to know that whatever you do would be in the best interest of the patient, not in the best interest of whoever is giving you the guideline. That should be evidence-based on that patient, on outcomes-based on that specific patient. We should stop working in silos.
Right. The Christmas time, I wish that South Africa comes back. And is there any narrative to WHO because of banning flights and all that after creating fear psychosis? Would you like to say anything on behalf of SAMA? You have a responsibility. A scientific body, Dr. Tedros comes out, a scientist comes out, they give statements. Where is the data? What is this organization is all about?
Well, from SAMA side, I'm going to again applaud our scientists. We really have good scientists that work hard behind the scenes. But we need to take the patients with us. We need to make sure that WHO are also, evaluating the situation. They should not be pressurized by political pressure to say things of certain countries that are unhappy if a country are saying that it's a mild disease, and then all of a sudden say, one day they will, there were statements that this is a disease that seems to be less virulent than previous ones. And once we said that, and UK started to see the increase in numbers, then all of a sudden it became a very, very severe disease, a viral infection. I just think we need to, we just need to not play the politics. Just do what is the right thing. Stop the politics.
Stop the politics, WHO and all the governments, including CDC, FDA, ICMR. Stop playing politics. It's health which matters. We are not dealing with the machines. Let us stick to the core science. The core science with logic evidences, as Dr. Amitav Banerjee, Dr. Khushwaha, and many other wonderful guests. Now the new one, Dr. Angelique Coetzee. We will all bring science as well as logic and evidences, so that you decide. The citizens of the world, you decide. We are not here to impose. No question of denying, because right to life, right to health is your fundamental right. And every government has got its responsibility to make you aware with all information so that you decide. And we are doing the same by having all these wonderful guests connected from different continents. So I'm thankful to all these wonderful guests once again. Before I leave, this retelecast will be on Saturday. That means 18th at 8 p.m. on Citizens Dr. TSPR channel. because tomorrow we will be playing chess. It was interrupted with Dr. Amitav Banerjee tomorrow at 8 p.m. And yes, know your enemy, military attire Dr. Arvind Khushwaha will be joining us next week too. These will be continued live shows on a subject which is of utmost public importance, and a big festival is happening now across the globe, Christmas and New Year Eve celebrations in the Western world. So to remove that fear psychosis, to see that people understand Omicron, oh my God, from the discoverer itself, very categorical and clear. No politics, it's a mild disease. That has to be borne in mind. A vaccine which should have reduced hospitalization and or transmission, still in the blah blah blah. So don't get worried. Trust your inner strength, inner soul, your own natural immunity, and take all those precautions which will really help you so that you can stay hygiene. South Africa is suffering. Nothing is coming out. I was trying to grill because she is the chair of SAMA. I think next week or depending on time, we will discuss what is happening in Johannesburg. No water, no sanitation. How is that those things are being ignored by World Health Organization, even the South African region unit, and trying to play COVID politics. And at least we have Dr. Angelique Coetzee with such courage stating that it is mild. She is warning the world, don't play politics. This is for today. So take care. For all the Indians, we say Sukha Nidra Shubharatri. For the world over, we say good morning, good afternoon, and good evening to you all. Support, subscribe Dr. TSPR channel, Citizen Dr. TSPR channel, and Environment People Dr. TSPR channels. You can send me all these videos as you have been doing. We will play them so that people will understand and appreciate. We can reduce the fear psychosis, that panic, so that people can live a merry and happy life without any ifs and buts, so that they are truly informed. Thank you, sir. Good night. And madam, very, very good evening to you. Namaskar. Take care. Hope to see you soon.
Namaskar. Thank you. Namaskar.
Right, sir. Good night.